Hello everybody, this is the preparation for practice arterial blood gas analysis tutorial, which would ordinarily be held on a Wednesday morning in the lecture theatre, but unfortunately we're having to do a distance. I've created this as a video so that you can pause at any time. This is James Pipe, one of the clinical teaching fellows, and this presentation was completed for you up to date for April 2020. So the aims of this tutorial are to, number one, give you a framework to analyse arterial blood gases in a stepwise and logical manner. 2, know the causes of respiratory and metabolic alkaloses and acidosis as applied in some clinical scenarios. Review the anion gap and its clinical relevance, and then finally we're going to proceed through some clinical cases to apply your knowledge. So why an arterial blood gas? So you may want to assess the metabolic derangement, so whether there's an acidosis versus an alkalosis, and this would be more likely to see an acidosis in acute emergency medicine. You may want to assess the ventilation, so is the patient hyperventilation versus the oxygen requirement, and again it's important to remember that these two are distinct and not mutually exclusive. You can be hyperventilating but have normal saturations as seen in a condition such as anxiety. It can be an indicator of severity of illness, such as a lactate measurement, and indicate whether the abnormality is acute or chronic, which gives us to the concept of compensation. Generally speaking, if your patient is poorly, they'll have an arterial blood gas done, but we'll come to some examples later as to why an arterial or venous blood gas may be equally appropriate. So this is an enzyme structure. This is the enzyme chymotrypsin, and the reason I've put this up here is to get us thinking back to the very early of your training in biochemistry. So it's important to remember that the normal pH range is between 7.35 to 7.45, so only 0.1 of a difference. But why is that? Well, it's important to remember that in order to function, we have aerobic versus anaerobic metabolism. Aerobic metabolism depends on oxygen, but it also depends on the stability of enzymes, so that everything we do, from cough to produce urine to sputum, are all dependent on enzymes, which are in turn made of proteins and amino acids, and in order for them to remain stable, they have a pH environment which they can work in. And so when your pH drops through acute illness, what will happen is that your tissues will switch from aerobic to anaerobic metabolism, your enzymes will start to break down, and so your tissues will start to break down, then your organs start to break down. So it's an important metabolic cascade, so it's important to remember why that the pH range is so important. Of course, the byproduct of anaerobic metabolism is lactate, which is why it's a good measure of anaerobic metabolism, although it's important to remember that you can't necessarily tell where that lactate is coming from. So we are basically like a human seesaw, in that we exist to maintain homeostasis or equilibrium, and you can see the equation there. So you have other things that we need to think about. So our buffers, so we have a chemical method of keeping ourselves in check, bicarbonate being the most common one. We have regulation by the kidneys, so we either will excrete hydrogen ions or will absorb bicarbonate. Then of course we have our respiratory backup mechanism, which will be either through increasing or decreasing alveolar ventilation. So remember, we want to stay as a nice straight seesaw. Remember also that these backup mechanisms such as bicarb or altering the rate of alveolar ventilation are all part of your backup system. So for example, if you metabolically tip one way, such as developing acidosis, you'll chew up bicarbonate in order to regain control of the seesaw. So normal ABG values, so pH, the acidity or the alkalinity of the blood, is between 7.35 and 7.45. PCO2, or the partial pressure of carbon dioxide in arterial blood, normal range between 4.7 to 6. Bicarbonate, which is a buffer, neutralizes the effects of excess acid, and that's a normal range between 22 and 26. Don't worry too much about base excess. This simply reflects the degree of excess acid or alkali in the blood in order to maintain or achieve homeostasis. And PaO2 is a partial pressure of oxygen in arterial blood, and this is usually between 11 and 13 kilopascals. Just to give you enough rough idea about when an arterial blood gas or venous blood gas is handed to you, the different types of values that you'll get. This is a very typical ABG printout from our radiometer machines, which we also have here at the Royal Free, and you can see that you would have the patient details. The arterial sample type is very important, whether it's arterial or venous, and of course how much oxygen they're on, which I'll come to in a moment. So 5-step approach to analysis. So the first thing to ask is, how is the patient? You want to get any medical history, whether there's any chronic respiratory disease or chronic kidney disease, and what of course is their presenting problem, and this will give you useful clues to help with the interpretation of the results. So the second thing you then want to ask is, what is the oxygenation? Is the patient hypoxemic? So when thinking about hypoxemia, I want you to have a look at this diagram closely. Now let's say we have two patients. The first patient is on a 24% Venturi mask, and we do an arterial blood gas, and it shows that his PO2 is 10, which is roughly in the normal range. Let's now think about patient B, who is on a non-rebreather mask, which gives you roughly 85% oxygen. We do his blood gas and their PO2 is 10. Well, you can think, well, that though both of those are normal. However, remember the patient B is much sicker, as in order to get to a normal value, the patient requires 85% oxygen compared to patient A, which only requires 24% oxygen to get a normal PO2. And this isn't quite the same as the AA gradient, but it's a similar concept about how much oxygen is required in order to get normal values. And this is why it's important to know how much oxygen or FiO2 the patient is on. Clearly the patient on the non-rebreather mask is much sicker than the patient on the Venturi, and not knowing the FiO2 when interpreting an arterial blood gas can lead to serious errors in managing a patient. So this is a really helpful tip if you don't know this already. So it's worth knowing that the PaO2 should be around 10 kilopascals or 75 millimeters of mercury when breathing air, but about 10 kilopascals less than the inspired concentration. So if we put on a non-rebreather mask onto a well patient with normal ventilation, normal lungs, normal perfusion, and you then do an arterial blood gas, then you'll find that the PO2 in that patient will be about 75 kilopascals. Now, if you were to do the same blood gas on the same amount of oxygen, but a patient who, let's say, has massive PE and the patient's PO2 is 20, well, that's still a significant gradient between the amount of oxygen being given to get the amount of oxygen going around the body. Conversely, if you have a well patient on about 35% oxygen, then the patient's PO2 would be around 25, therefore you could probably reduce the oxygen further. So knowing these bits of data is important when titrating oxygen therapy, such as in COPD, or deciding whether you're going to ventilate either invasively or non-invasively one of your patients. Now, when you first look at blood gas, some people will do pH first. You want to decide whether the patient is acidemic, i.e. have a pH of less than 7.35, or alkalemic, greater than 7.45. I don't have a particular preference. I personally tend to do pH first, but when you do assess the oxygen, it is important that you re-reference how much oxygen that the patient is on. So you then want to determine the respiratory component. So if the pH is less than 7.35 and the PCO2 is elevated above 6, we describe this as a respiratory acidosis. If the pH is 7.45 and the PaCO2 is less than 4.7, then we describe this as a respiratory alkalosis, and you are going to see clinical scenarios where both of these occur. And finally, you're going to determine the metabolic component. So this is where you're now focusing on the bicarb rather than the CO2. If the pH is less than 7.35 and the bicarb is less than 22 millimoles per litre, then this will be a metabolic acidosis. If the pH is 7.45 and above, and the bicarbonate is greater than 26, this is known as a metabolic alkalosis. What is an anion gap? So the anion gap essentially is the sodium in millimoles per litre minus the chloride plus the bicarbonate ions in millimoles per litre. We can do this to help classify a metabolic acidosis. A high anion gap is caused by an increase in unmeasured ions, and examples of this are ketoacidosis, uremic acidosis, drug ingestion such as salicylates and methanol, ethylene glycol or antifreeze, and lactic acidosis. You may have a normal anion gap acidosis, which would be commonly seen in diarrhea, pancreatic and biliary secretions, fistula and ileostomy, and proximal renal tubular acidosis. Remember, the normal anion gap is between about 10 to 14 milliequals. So, in summary, your 5-step approach to arterial blood gas analysis are: how is the patient, assess the oxygenation, make sure that you know how much FiO2 or if they're on any oxygen at all, determine the pH, determine the respiratory component, and determine the metabolic component. We are now going to work through 5 scenarios, and the aim of these is to apply what we've just learnt. So these are from the Resuscitation UK workshop on arterial blood gases with copyright credit to them. Have a pen and paper ready, and remember that you can pause the video at any time. Try and work through these before pressing on or forwarding on to the answers. So we're going to look at this one together. So this is case study number 1. We are called to the emergency department to see a 21-year-old woman who was thrown from her horse at a local event. On the way to hospital, she has become increasingly drowsy. After receiving a S-bar handover, you perform a rapid ABCDE assessment and find A, that she is tolerating an oropharyngeal airway and is on 85% oxygen. Her respiratory rate is 8, her SATs are 99, there is reduced equal air entry on both lungs, her pulse is 54, blood pressure 166/105, she has a GCS of 9. Okay, so let's pick out some of the issues in this A2E assessment. She's tolerating an oropharyngeal airway, and remember that in order to do that you need to be unconscious. Her respiratory rate is 8, which is low, which means she is hypoventilating. So have a think about what this will mean for her carbon dioxide. Her saturations of 99, again, you need to be careful about when interpreting saturations, which is the same way as, again, saturations and breathlessness and ventilation or quality of ventilation are not the same thing. So she has reduced equal air entry, so think about why that might be. Notice that she has a bradycardia and hypertension. If you can remember the response of this, it begins with a C. She has a GCS of 9. So remember the first of the 5 steps in analysing an arterial blood gas sample. So how is a patient? So, well, we know that she, from her A2E assessment, that clearly this is a young woman who would normally physiologically be well, that's had a significant major trauma. Pause the video here and write down what your thoughts about what you might expect on a blood gas and also in your A2E assessment. Think about some of the common trauma conditions that you might see. So she has clearly a reduced level of consciousness as determined by the presence of the oropharyngeal airway. So she's had a significant head injury. Therefore, this will impair her ability to ventilate, and she has a significant head injury as also evidenced by the Cushing's response, which is seen by the bradycardia and the hypertension. So her reduced level of consciousness will impair her ability to oxygenate and to ventilate. Now imagine being thrown off and kicked by a horse. You're likely to get significant thoracic injury, so she could be hypoxic from significant lung injury, so hemopneumothoraces, flail chest, broken ribs and so on. She will have an increased CO2 because of her reduced level of ventilation. So remember, she had a respiratory rate of 8. In time, your CO2 level will slowly build as you are unable to clear it through ventilation. So this will cause a respiratory acidosis, so i.e. a high CO2 and a low pH. This is a hyperacute trauma situation, and in the trauma circles we talk about the golden hour, so therefore a change in bicarbonate is unlikely because of the acuity of the situation. So let's go on and have a look at her gas. So she's breathing 85% oxygen. She has a PO2 of 18.8, pH 7.26, CO2 8.2, bicarb and base excess are essentially normal. Now again, the first thing to recognise here is about how much oxygen she is on compared to the actual blood level of the ABG. So what are we going to do now? Well, we're going to assess the oxygenation. So let's have a look at that. Remember that your PO2 should be 10 kilopascals less than the fraction of inspired oxygen. She's on 85%, so we'd expect 75%. Hers is nearly 20, so again the gradient there is about 60. Therefore, she probably has significant chest and thoracic injury. We're going to determine the pH, so she has a pH of 7.26, therefore she is acidotic. We're going to now determine the respiratory component, so her pH is less than 7.35 and her PCO2 is greater than 6, therefore she has an acute respiratory acidosis. We're now going to determine the metabolic component, so let's have a look at her bicarb. It's in the normal range, therefore this is primarily going to be an acute respiratory acidosis, secondary to the head and thoracic injury. So, in summary, this patient has an acute respiratory acidosis with impaired oxygenation, and this is because of the acuteness of the situation. There is no compensation. Now we're going to move on to case 2. So case 2, you arrive in the emergency department and are met by one of the staff nurses who gives you the following handover. This is Mr. Brown, 63, who has been successfully resuscitated. I think I'd probably put successfully in commas as to how do you define a successful resuscitation, but that's a discussion for a different day, after an out-of-hospital cardiac arrest. He arrested about 20 minutes ago, therefore there's going to be no metabolic activity, so think about what that's going to do to your lactate and your acid status. Had bystander CPR. When the paramedics arrived, he was in ventricular fibrillation and got return of spontaneous circulation. This is otherwise known as ROSC after the second shock. He is intubated on 50% oxygen, so again think about what PO2 you might expect. Saturations are 90% with a systolic blood pressure of 130, heart rate 120. An ECG has been requested and some blood gases have been sent. So of course you have a rough idea about how the patient is. This is someone that's been in cardiac arrest, so think about what that's going to do and what might have happened to the patient and what their respiratory and metabolic state might be like. So pause the video here and think about what you might expect on a patient's arterial blood gas. So the patient is going to be hypoxic as a result of likely aspiration as seen in cardiac arrest, pulmonary edema, pneumothorax from chest compressions, alone or in combination. The patient is likely to have an elevated CO2 due to the period of hypoventilation. Obviously there's been a significant period of anaerobic metabolism, which of course has a byproduct of lactate, which means the organs will be malfunctioning, so there'll be a lactic acidosis and a low pH. Some time has ticked on by now, so there will be a consumption of bicarbonate in attempt to buffer the significant acidemia that the patient will have. So let's look at the blood gas now. So the patient is ventilated with 50% oxygen. An arterial blood gas analysis reveals the figures. Pause here, go through the remaining steps to complete your analysis about what you would expect. So these are the numbers. So he obviously has a significant acidosis here. This is typical ABG result after prolonged cardiac arrest. There is a mixed metabolic and respiratory acidosis, the predominant component being metabolic. So you have two processes going on here, and that's why you have a mixed acidosis. So the first thing about the metabolic aspect is that, of course, as soon as you have cardiac arrest, you have no organ perfusion. Therefore, you'll switch from aerobic to anaerobic metabolism, which will, of course, build up your lactic acid levels and drop your pH as the cells start to break down, leading to tissue and organ malfunction and breakdown. There'll also be a respiratory acidosis because don't forget, of course, during cardiac arrest you also don't breathe, so there's no gas exchange and there will be a build-up of CO2. Once you're intubated or ventilated, then obviously your CO2 level will start to fall, but at the moment that hasn't happened yet, so he is still requiring further ventilation to bring his CO2 down. Case study number 3. So we are called urgently to the ward to see a 71-year-old male patient admitted with an acute exacerbation of COPD. So again, think about the likely state of his lungs and how efficiently they work in terms of gas exchange. The nurse gives you an S-bar handover, so situation, background, assessment and recommendation, following which you carry out a rapid ABCDE assessment and find that. Again, have a quick look at this, think about what are the key things in this A to E. So immediate things that should jump out to you are the fact that he has an oropharyngeal airway, which means the patient is unconscious. He's being ventilated with 15 litres of oxygen. I want you to ask yourself at the moment about, is that the right thing to do even though they have COPD? And remember, the answer is yes, for now. Remember that even with COPD, it is not hypercapnia that will kill these patients, it is hypoxia and terminal ventilatory failure. Obviously, we don't want a patient like this on 15 litres of oxygen for prolonged periods. In fact, NIV or non-invasive ventilation, or otherwise known as BiPAP, may be the treatment. But in the initial phase, this patient is profoundly hypoxic and needs oxygen until you can get to the cause as to his hypoxemia. So his saturations are 90%, so remember that that's in the normal sat range, but again we are requiring 15 litres of oxygen, so again there's a big discrepancy there. He has a widespread wheeze in both lungs and coarse crackles at the left base, so he's probably got a hospital-acquired pneumonia with exacerbation of his wheeze on top. He's unconscious as demonstrated by his bradycardia and hypertension. He's got a GCS of 7 and there is no else to be found on examination. So, having reviewed the patient's drug chart, you take an arterial blood gas. From your ABCDE assessment, what might you expect on a blood gas? Pause the video here and write down your thoughts. Also, have a think about why you would check the patient's drug chart. So, from your ABCDE assessment, you might expect impaired oxygenation due to his underlying disease. He's had a respiratory arrest, therefore there will be no ventilation, therefore there will be no exchange of gases and his CO2 will be elevated. He'll also have a reduced pH as this is an acute respiratory arrest, but this is probably someone that will have signs of compensation for his chronic respiratory acidosis, therefore they are likely to have an increased bicarbonate even in an acute situation such as this. Now, why did I also ask you to think about why we would scrutinise the drug chart? So, breathlessness in COPD is an extraordinarily difficult symptom to manage, and at the end stage of COPD, we will often prescribe low-dose opiates. So it's possible that the patient has given themselves an inadvertent overdose. Also, if you think about how many courses of steroids that a COPD patient will have over a lifetime, it's likely to be lots if they have brittle disease. Therefore, they are likely to develop osteoporosis and possibly develop osteoporotic fractures, which can be significantly painful, particularly, for example, if they're in the spinal vertebrae. Therefore, often patients like these are often on morphine tablets or morphine patches. So it's always important when you think about your E for exposure or reversible causes in cardiac arrest, think about what patients' drugs they are taking and whether there are any patches in situ. So here's the arterial blood gas. Have a look at results, pause here and go through the remaining 4 steps to complete your analysis. What sort of respiratory failure is this? So this patient has impaired oxygenation. As you might expect, he has almost like think about lungs as a shriveled sponge where you can't get the ventilation or air through properly. So that will mean that he has a persistently high CO2, hence the elevated bicarbonate to try and balance things out. Remember that we have to think about the human body as a seesaw that we're trying to keep straight. He has a significant acidemia, so he has an acute respiratory acidosis because of the respiratory arrest. This is otherwise known as acute on chronic respiratory failure or type 2 respiratory failure. Type 1 respiratory failure being primarily hypoxemia, type 2 primarily being hypoxemia with hypercapnia. Case number 4 of 5. So you're called to the emergency room to see Mrs. Harris, who is 86, who has had an out-of-hospital cardiac arrest. She's been intubated, she has a return of spontaneous circulation, she has a handover which is as follows. So she's intubated, she has a 7.5mm diameter tube, 22 cm at the lips. And just as an FYI, what that's telling you there is in the tube is appropriate size for her, 7.5mm diameter, and that 22 is a fairly standard placement for ET tube at the lips. She is having manual ventilation with a bag valve mask with oxygen at 15 litres, and she's being ventilated at 20 breaths per minute. Now her end tidal, which is mandatory when a patient is intubated and ventilated, is at 2.2. Let's just pause here and think about that for a moment. So she's getting manually ventilated. So there's a potential for hyperinflation injury. 15 litres, 20 breaths per minute. Now remember, we want to try and get patients post-cardiac arrest into a normal physiological state. So is 20 breaths per minute the right thing to do or not? No. So she's being over-ventilated. So again, think about how that will appear on her blood gas. She is tachycardic and hypotensive. She's had a cardiac arrest, so again, think about what her metabolic state is likely to be. So from your ABCD assessment, what might you expect on a blood gas? Again, pause the video here and write down your thoughts. So, she's likely to have an impaired oxygenation due to the complications of the arrest, as I've already outlined. She will have a low PaCO2 due to excessive ventilation, so she'd only really be ventilated between 10 to 12 breaths per minute. The excessive ventilation will do her harm. She'll have an alkalemia and a raised pH from the excessive ventilation, but she'll also have a metabolic acidosis from anaerobic respiration as during the cardiac arrest, so she will have a low bicarbonate. So let's have a look at her gas. These are the numbers here. Again, pause here, go through your remaining steps and to complete your analysis. So she has an impaired oxygenation despite a PO2 in the normal range, a respiratory alkalosis from the excessive ventilation, and a mild metabolic acidosis from the anaerobic metabolism from the cardiac arrest. And this is our last case now, number 5. Mr. George is an insulin-dependent diabetic who has been vomiting for 48 hours. Because he was unable to eat, he has taken no insulin. The nurse gives you an S-bar based handover and you carry out a rapid ABCDE assessment. Let's pick out some of the key bits. Respiratory rate is 30. Oxygen 6 litres per minute via a face mask with SATs of 96. There's good air entry on both sides, but you can smell ketones. So just focusing on that for a moment, so there's an elevated respiratory rate, but his oxygenation appears normal, and this is a relatively common finding in the condition, which I'm sure you are aware is DKA, diabetic ketoacidosis. Now, again, it's important to understand and remember that oxygenation, ventilation, and respiratory rate are not mutually exclusive, and so the reason his respiratory rate is high is, of course, because he's acidotic, not because he has a primary lung pathology, and that's a very common finding in DKA. Very often with DKA, patients who are admitted have compliance problems, gastroenteritis, viral infections, but very rarely have a primary lung problem such as pneumonia. The patient is tachycardic and hypotensive, so again that goes towards the acidosis and also from the diuresis and osmotic effects of the DKA. His GCS is 13 and he is confused. Now that should be a red flag to you when managing diabetes. I'm sure my colleague Dr. Carroll will go through with you. You want to be very wary about these patients developing cerebral edema from the osmotic effects of the DKA. Slightly distended abdomen, so again you'd be wanting to think about, is there an intra-abdominal source for his DKA? Is it someone, we don't know the age of the patient, but is it someone who has got mesenteric ischemia, or is it someone who's got diarrhea and vomiting, or a tumour, for example? So think about from your ABCD assessment what you might expect on a blood gas. Pause the video here and write down your thoughts. So he's got type 1 diabetes, he's likely to be acidotic with a low pH, he will be hyperventilating to try and blow off the acid, therefore he will have a low PaCO2. He will have a reduced bicarbonate as a result of buffering of the keto acids, but no significant impairment of oxygenation. Let's look at his gas. So again, pause the video here, go through the remaining 4 steps to complete your last analysis. So there is no impairment in oxygenation, therefore he doesn't require high flow oxygen. He has a primary metabolic acidosis with partial respiratory compensation, and it's partial because his pH remains low, but he's hyperventilating to try and blow off the acid. These blood gas results are consistent with severe diabetic ketoacidosis. Further evidence is the presence of ketones and the high blood glucose. These patients need careful monitoring. They do well with good bedside management and careful management of their USNEs and fluid status. Touch wood, I haven't needed to admit a DKA patient to ITU, and it's a sign of good general medicine when you don't have to admit these patients to ITU. So if you have any questions, of course, about this presentation, you can email me at james.piper@UCL or Royal Free Teaching Fellows. There is a practical demonstration which ordinarily we would do with you and sign off your books, but there is a UCL ABG demo which is on the YouTube link there. I would just caution you about the music. It does come across as like a trashy porn movie or a very bad Australian soap opera, just to warn you about the music. However, otherwise it is a very good demonstration video. Thank you all for listening as always, and I look forward to seeing you in person soon. I'd also like to give credit to the Resource Council for providing the framework for these slides.